So we've had this Innovators lecture series, and it's covered a lot of ground, everything from brain-computer interfaces now to pressure ulcers. How can you get more varied than that? And this is something that's going to probably be the bane of many of your existences, even though it's something that many of you just see after you've done a repair. And this is, and nothing ruins that like real life, and this is about as real as it gets. And I can't think of anyone more real than to bring it to us now. So Bill comes to us being recruited from Johns Hopkins. He is an elite pharmacoeconomist and is over at the Schaefer Center here at USC. And he's on the National Board of Directors of the National Pressure Advisory Panel and a lot of other things. And I really look forward to having him here. I think this is the beginning of a beautiful relationship when it comes to health policy and health economics and whatnot. So, Bill Padula.
Thanks. This is the remote?
No,
this is the
just use the keyboard.
Okay.
Yeah, definitely don't use the mouse.
Yeah.
Great. So,
Yeah.
just understanding, are most of you in fellowship or attendings or residents?
We're really all in
A mix.
fellowship together
Yeah,
around the patient.
lifetime.
We're all Dr. Armstrong's.
No, this is
Kids.
so you have a variety of vascular surgery,
Okay.
a podiatric surgery,
Oh, great.
nursing,
Okay.
and what else? Of course, we have interns and residents from a variety of
I
specialties.
see. Awesome. All right. So I get to reach out to everybody, which is
You
what I
sure,
like
you sure
most.
do. I think this is something they're not thinking about a lot
Yeah. So
until it happens.
I'll just, I think this is a good presentation for today because it's not too boring science, economics heavy. So I wanted to focus this actually as a lecture I created 3 days ago for the NPUAP national meeting, and thought it fit well here because it's about quality and safety, it's about policy, and it's about what can you do at the hospital level to improve outcomes with respect to pressure ulcer prevention, or as the National Pressure Ulcer Advisory Panel now calls it, pressure injury is the new buzzword. So I'll take you through some regulatory and compliance issues that I believe are great to start right here locally, in the sense of most pressure ulcers actually are an issue related to coding and staging. It's not all about prevention. What we find is that at places like Keck, for instance, quality is already really good. And so most of the hospital-acquired pressure injuries have gone down realistically, but they still get put in the EHR because people are confused, right? They think a DFU is a pressure ulcer, they think a terminal end-of-life skin breakdown is a pressure ulcer. And so think about some of these points of confusion where it takes a village and it takes a team like this in order to change the way that we think about what's caused by pressure and friction and what's caused by something else in the EHR, because this affects how the hospital looks in terms of its quality. So I'll take you through that and get towards some ideas. I call this through the looking glass because if you get bored, you can just watch this PowerPoint like it's an Alice in Wonderland movie. But ultimately what I want to do is turn pressure ulcer prevention on its backside and think about the larger issue of improving quality and safety in hospitals through the prevention of hospital-acquired conditions as a whole, and using pressure ulcer prevention, the protocol, as a framework for thinking more broadly about preventing many things at once. So I'll take you through all of this. And I have all of my disclosures as usual. But I'll start with this opening scene in Alice in Wonderland, where the idea is that things look easy from above, and if you look at pressure ulcer prevention, it should be easy too. I don't know why there's two boxes, but it's not supposed to be like that. But pressure ulcer prevention is simply a 5 or 6 step checklist where you start with skin check and risk assessment with a standardized tool like the Braden scale upon admission. And then most of this is labor intensive, where it's driven by nursing time to reposition the patient frequently. It's managing their nutritional levels if they're malnourished. It's ordering the right support surfaces underneath them, managing their moisture and incontinence issues, and continually investing in nursing education about the guidelines for prevention. So this looks relatively easy, right? But what we know in general from hospital quality and safety campaigns is that this requires a lot of investment, is a long-term goal just to get these things standardized. So while it looks easy from above, it's much more complex when you get into the nitty-gritty of making this consistently implemented with every patient every 24 hours. And that's what I like to set apart as the complexity of pressure ulcers compared to the prevention of other conditions, like take central line associated bloodstream infection. You don't have to worry about preventing CLABSI unless the patient needs a central line, right? As opposed to what you have here in pressure ulcer prevention, every patient that's laying in a bed is at risk for one, all the time. So this is a checklist that needs to continually be implemented every 12 to 24 hours, and with repositioning, the indication is really every 2 to 4 hours. And so when we look down the rabbit hole, we see a lot more than what policymakers see. What CMS sees is that checklist. What we experience in the hospital is a lot more driven by socio-behavior complexities and processes that need to be improved. And I like to start with some of the economics of the issue, because when you look at this, this isn't a small deal. This paper in JAMA by Don Berwick and Hackbarth estimated that out of all the waste that we invest in healthcare, or spend wasting in healthcare, 36 to 45 billion as of 2011 was estimated on failures of healthcare delivery. And something like pressure ulcers fits right in with that failures of healthcare delivery, because if we believe that most of them are avoidable, then every time one happens, it was a failure to implement one component of that checklist, even just once across several days that a patient was in the hospital, forgetting to reposition them one period in that 2 to 4 hour range could have been a failure. And furthermore, we have to remember, you know, I'm not a clinician, but I have a lot of respect for what you all do here as teams of nurses and physicians and podiatrists and therapists and the like, that a patient needs to have many things managed all at once. And this paper by Creditor, it was a long time ago in Annals of Internal Medicine, but he highlighted over 25 things that need to be managed simultaneously using evidence-based guidelines in order to safely discharge the patient. And you can't see it very well, but here's pressure ulcer. So he highlighted that as one of the key things that needs to be managed to safely discharge the patient. But obviously when you have all of these different items that you have to manage, it's hard to implement everything at once. And so it gets to that Swiss cheese effect, if you've heard about it before, where you have lots of holes through the layers of the chunk of Swiss cheese, and missing out on one thing can send a patient down a path that could lead to death or a longer hospital stay, like with pressure ulcer. You know, I think the other issue here is that in this topic of hospital safety and quality, the issue is that the cases we prepare for are not the patients that we care for. You have so many situations where this checklist looks simple and you think, okay, I can do this, I can reposition the patient every 2 to 4 hours. But what happens if your patient's morbidly obese, right? As we see often here in these academic medical centers. It takes not one, but 3 or 4 people to reposition that patient if you can do it at all. What happens if your patient's comatose or critically ill, frail, malnourished? You know, I've talked to so many nurses, and I'm sure you've heard the same stories, where after, say, a patient who's gone through a heart transplant procedure, the nurses are scared to even tilt them a couple of degrees angle. So these are issues where the guidelines don't help us much. And furthermore, we have all this confusion about what is a pressure ulcer? What is caused by pressure and friction? And where do we divide the line with some of these other end-of-life conditions, like what we now refer to as the Kennedy terminal ulcer, which for decades has been coded as a pressure ulcer, but there is, in fact, a difference based on the existing evidence that we have. And so being able to differentiate these isn't going to help the patient, but it will help the hospital. And if you think about the value in that, if the hospital can save money by not being penalized for high pressure ulcer rates, and that's money well spent somewhere else, right? Either in your pockets or in a new hospital safety and quality campaign. So wherever we can save, it's worth it. And getting some of these differentiating factors between what's caused by pressure and what's caused by end of life is critical. And so I'll take you through the navigation of the US healthcare system, because I'm a policy researcher. And I think sometimes it helps in your world, you're here, you're in the trenches every day. Who are the stakeholders way up there that are involved in pressure ulcer prevention and hospital safety and quality as a whole? And I think you can guess some of them, but I'll give you some of the dynamics of what's been going on over the last few years with groups like CMS and AHRQ and some of the local advocates like the National Pressure Ulcer Advisory Panel, American Hospital Association, and what they face using statistics, using epidemiology and economics with the burden of pressure ulcers, and thinking about where we can go knowing each of these stakeholders' interests. So let's start with CMS. CMS is a pretty stern red queen, I would call it, with respect to how we as a community have to deal with pressure ulcer prevention. And it goes back to 2008. So if you don't know this or remember this, in 2008, CMS instituted a non-payment policy on all hospital-acquired conditions. And it actually started with a small list of 8. Pressure ulcers were part of that first small list. And then they kept broadening it. So in 2009, they added 3 more and 3 more. So we've ended up with this situation now where all pressure ulcers coded as this measure called Patient Safety Indicator, PSI-3, are not paid for, and therefore hospitals have to reabsorb the cost of treatment for pressure ulcers in acute care. And based on that Berwick and Hackbarth paper, it's a theoretical redistribution of $40 billion that CMS used to pay for, and now hospitals have to absorb that $40 billion across the country. And to give you some sense of this, I actually looked in these data when I was doing graduate work at University of Colorado Hospital. We looked at the average reimbursement prior to 2008 for a patient with an AMI who then got CAUTI. Okay, and there were several cases of this, so we were able to do a case series on it. The patient with an AMI who came in on average got the hospital $5,400 from Medicare for whatever it was, their 3 or so day length of stay. If that patient then developed a catheter-associated UTI, the hospital got an extra $550. And then if that patient became septic from the UTI, the hospital got an extra $1,600. So this story wasn't incentivizing prevention. There was a real conflict of interest here that CMS was creating. And so this non-payment policy hopefully would have had an effect, and I'll show you the real data. But when they moved ahead, and they've continued to crank it up since that 2008 call to stop reimbursement, and as of 2014, now hospitals get penalized 1% of their total CMS reimbursement. For a place like Keck, that could be $4 to $5 million a year. If they fall in the bottom quartile with respect to a composite rate of 11 hospital-acquired conditions, which include pressure ulcers. And the measure for these 11 never events and the composite rate, this is called Patient Safety Indicator 90. Hospitals are going nuts over this right now because obviously they don't want to fall into the bottom quartile. And it's a weird system because when you think about it, if you think like I do about behavioral economics, that there's no incentive to perform well, there's just an incentive not to perform poorly, right? So where's the reward or the pot of gold at the end of the rainbow here for being a really good performing hospital? That's something I'll get to later. So I'll show you some data here that have been the fallout of these payment models where the stick approach going back to non-payment policy, we did an analysis of the rates of pressure injuries across 55 academic medical centers, which included USC actually, and other medical centers in the Vizient UHC database. And we saw a significant decrease adjusting for a lot of different covariates. Right when that CMS policy began to take place, the rates went down. And so controlling for coding issues and some of the other things, there was a significant drop in the rate of pressure injury. And it's interesting how the announcement came in April of 2007, so hospitals had about 18 months to react to the announcement that non-payment. So hospitals began to ramp up quality improvement well before the reimbursement changes took place. So let's say non-payment policy worked, but CMS took one step to improve hospital quality, and they saw it work, so they ramped it up and they said, let's go full throttle on penalizing hospitals for poor performance. And I think they went a bridge too far, where when you look at these data these are data from published by CMS at their All Partners meeting last year across 800 hospitals in the United States in this All Partners or HIIN network that CMS tracks in partnership with Premier and Vizient. And what we saw is that pressure ulcer rates were going down consistently right up until 2014. And as soon as they instituted this penalty system, pressure ulcer rates began to go up. Why do you think? Any guesses? I'll get to it, but anybody have any hypotheses so far? Why would pressure ulcer rates go up as part of a composite rate for hospital-acquired conditions? I'll come back to it, but that'll drive you nuts for the next few minutes. So then we have AHRQ, which I kind of think like the Cheshire Cat. It's this shape-shifting organization with respect to how it measures hospital-acquired conditions, and it's a moving target. We can never quite get prevention of pressure injury right, especially from a coding standpoint, because they keep changing the definition of what a hospital-acquired pressure injury or hospital-acquired condition is. I'll show you how. So AHRQ creates these patient safety indicators, these nursing quality indicators or hospital quality indicators, whatever you want to call them. And so these are critical for hospitals to improve upon in order to avoid these penalties now. When AHRQ set out to define PSI 03 back in the early to mid-2000s, they defined a hospital-acquired pressure injury as a stage 3, 4, or unstageable full-thickness wound as a secondary diagnosis not present on admission after X days. And this is the complication because the number of days keeps changing, where in 2009, I guess I activated it, right? In 2009, not present on admission was after 5 days length of stay. Okay, so a hospital essentially had five days from the time of admission to do skin checks and ensure that if a patient had a wound, then the hospital wasn't going to get penalized for it. As of 2015, they bumped that down to 4 days, and then in 2017, they bumped it down to 3 days. And today, you have to document present on admission status within 24 hours. All right, so the pressure is really on. And that makes this composite rate of 11 PSIs more complex, I think, with this PSI 90 concept. And what goes on here, I asked you the question, why is this way? And my theory is that it's because of the fact that when they created PSI 90, pressure injury, or PSI 03, was established with an unequal distribution of the entire PSI 90 rate at 6%. So some other conditions, like it was the really funny one, like when you leave a scalpel in a patient after surgery and seal them up. Some of those never events, the sentinel events, that was weighted at close to 15%. So obviously, like one case of that is 15% of your total PSI 03 rate. So I guess systematically, what do you think is a more straightforward process to avoid? Leaving a scalpel on a patient or preventing a pressure ulcer? I think systematically, we can, with things like the surgical safety checklist over the last 10 years or so, systematically, we can do more to avoid that one situation where a scalpel is left in a patient. But preventing all pressure injuries on a hospital is challenging. So hospitals see this as a huge advantage point, where 6% means that we can let our pressure ulcer rate go up as long as we drive down the rates of all of our other hospital-acquired conditions, and PSI 90 remains level. So then these hospitals that know how to game those numbers don't have to worry about getting penalized for PSI 90. And So I started talking with AHRQ and saying, this is bogus, and your pressure injury, they didn't realize it. When they looked at their own data, they didn't see that their pressure injury measures are going up because hospitals are prioritizing other hospital-acquired conditions that they can manage more directly. And so now, in the last couple months, AHRQ switched to an equal proportion for all PSI 90 conditions. Now pressure injuries is 9%, as are all the rates of other hospital-acquired conditions on that list. But when you look at the treatment effect from AHRQ, it's been pretty steady where, interestingly here, this was only due to changes in coding. Okay, so the shift in pressure injury rate after 2008, when AHRQ defined PSI 03, coding accounted for a huge drop in pressure injuries. It didn't have to do necessarily with quality and improved prevention. It had to do with coding and correctly taking the time. Now that we're going to lose money on PSI 03, taking the time to code a PSI 03 hospital-acquired pressure ulcer properly was a huge milestone for these hospitals. So I see this as a correlation with changes in coding, which was a bigger lead than the CMS non-payment policy itself. Where are we now? Since these penalties have been instituted for the PSI 90 measure, most hospital-acquired conditions have gone down significantly, and CMS claims an 8% achievement, saving 8,000 deaths and $2.9 billion between 2014 and 2016. Of course, it's no surprise, right? The two rates that went up are pressure ulcer and CAUTI. So in that same time period, we've seen the same increase that CMS observed in its HIN data. And again, I think it's because when you look across here, some of these rates only need to be managed when a patient is on the operating table or is getting a central line insertion, whereas pressure injuries and moisture management need to be managed continually for all patients. So the implementation of the prevention protocol is more complex, and the rates weren't incentivizing, the PSI 90 disproportionate rate system wasn't incentivizing pressure injury or CAUTI prevention, so these have skyrocketed. And this is where the problem lies nationally. We have other stakeholders that I'll highlight in just a slide or two and point out, who's going to pay for research or to improve pressure ulcer prevention and outcomes. And you think because this is a nursing quality indicator that maybe you'd get money from an institute like the National Institute of Nursing Research. But I love this picture from the Carpenter because I see NINER, as it's called, buried in the sand. Of all the NIH budgets, it has the lowest budget, okay? $136 million. You've got NCI and other groups with billions of dollars to spend, and so 136 million, as you put it in your perspective, that barely pays for the K awards that go out to nursing researchers across the country. So they're really, this paper series that some colleagues and I worked on for Annals of Internal Medicine really focused on the fact that we're not going to get better at pressure injury prevention just trying to do this ourselves. And there's no support, despite CMS making this a priority area for prevention in AHRQ2, there's no support from the federal government to solve this problem. So hospitals are really left to their own to try and figure it out. We have the American Hospital Association as a representation of how is it helping us get over these hurdles that are created by CMS and AHRQ in order to improve quality. And I think hospitals have accepted their role that they're not going to get reimbursed for poor quality outcomes, so we have to invest in quality improvement. And what I've seen is that doing a survey of academic medical centers, those hospitals that responded positively to the CMS non-payment policy as of 2008 invested significantly in QI, and this is a representation, this curve, of how many hospitals have increased their the number of quality improvement programs that they focus specifically around pressure ulcer prevention. And one model in particular that we worked on showed that those hospitals which maintained a strict educational program that followed the guideline updates on pressure ulcer prevention from the National Pressure Ulcer Advisory Panel saw statistically significant reductions in their rates compared to all other hospitals that didn't follow these educational protocols. And to give you an idea of this, because I'm on the board for NPUAP, we release guideline updates for pressure ulcer prevention every 3 to 4 years. And that's based on best available evidence, right? So we create this 80-page document that grades the evidence for all the types of things that you might do to help a patient at risk for a pressure ulcer, like order them a higher tech bed, one of those $50,000 Hill-Rom beds you see around the hospital. Or now one of the things that's in style is putting prophylactic dressings on patients who are decubitus. And so understanding those, the guidelines and educating nursing teams about it has led to a 27% reduction in pressure ulcer rates in these hospitals compared to the ones that didn't follow these educational guideline updates. I love this quote recently published in Journal of Patient Safety and Risk Management by Albert Wu, who's a physician scientist at Johns Hopkins Hospital. Most of the progress has been piecemeal, largely because most of the support has been aimed at specific targets. Patient safety officers find themselves struggling with the whack-a-mole dilemma. A new problem arises as soon as one solves the first problem, resulting in incomplete or temporary results. This happens all the time in hospitals, right? If we campaign on pressure ulcers today, we see the rates go down. But in a year from now, once pressure ulcers are stabilized, the hospital CEO or CNO or CMO says, all right, we're going to move on to CLABSI prevention. And CLABSI goes down, but pressure ulcers go back up. So it really is a whack-a-mole concept. And we need to think about a policy that can drive down everything consistently. I think that's what PSI 90 was supposed to do. But because of the disproportionate rating scale, it didn't work out that way, and we see the proof in the AHRQ data that I showed you a few slides ago. So what can hospitals do to stabilize the prevention of all hospital-acquired conditions at once? We get to another group, and I love working with woundostomy continence nurses because they're usually the champions when it comes to creating a team around a pressure ulcer prevention. And that's not always the case at every hospital, but I'll use WOCNs as a representation of the White Knight, which is really a good, strong team working together, made up of a multidisciplinary unit that focuses on the prevention of pressure ulcers and other hospital-acquired conditions. And what we see from a survey of WOCNs across the UHC Academic Medical Center Consortium is that they've tried everything. This is a list. It's a busy slide, but this is a list of every type of hospital or every type of quality improvement intervention they've tested on pressure ulcers and trying to discern what worked. And so they have worked on leadership interventions to engage leadership, to support education, to provide financial support for quality improvement programs in pressure ulcer prevention. They've worked on creating forming teams of multidisciplinary staff in order to address and educate. I remembered working when I worked at Dartmouth-Hitchcock Medical Center up in New Hampshire, the MDs on a particular unit in surgery didn't really have any exposure to what the Braden scale was, the risk assessment tool for pressure ulcer prevention. And we actually spent time educating the surgeons on that ward about the Braden scale, and they got really interested in it, and we're starting to chart Braden scales with the nursing staff. And so there was equal responsibility on the part of all the clinicians looking after a patient to ensure that Braden scales were charted every day. I'll just add, there's IT interventions, and obviously this is getting better now than it was when they did this survey. And then finally, there's these performance and improvement interventions, which include things like visual tools that you can display on units to highlight the risk of certain patients, visual tools in a break room like this where you show the guidelines for prevention. The staging system has been improved, beds have been improved, and incontinence repositioning and nutrition systems have all been improved. So these things seem to work, and it's teams like this working together that achieve forward progress for quality improvement. And what this is a graphical depiction just showing that those hospitals that were successful at significantly reducing their rates of hospital-acquired pressure ulcers were intervening with leadership on all levels. So you can never emphasize enough that leadership support for this kind of work, either at the divisional level or at the hospital level, is critical to the success of these kind of quality improvement programs. And then we'll look at the role of what has happened with the NPUAP, just to give you a sense of where it sits in this matter. And I like the representation in this slide because we keep getting swept away by whatever the changes are in CMS and AHRQ and the like, and just trying to keep up with that, in addition to all the research that comes out and trying to systematically review it to consolidate the evidence. And so the key thing here is that as the evidence has grown over time, so has our understanding of pressure ulcer prevention, and we have a new guideline coming out in 2019 that I think will be landmark. And I have exciting news to share in that the NPUAP guideline launch is going to be hosted right here at USC. I've arranged for it to be at the USC Schaefer Center on the main campus. So if this is of interest to you, then it's an open invitation for all of you to attend. So moving on, I've mapped out the stakeholders that I think are important. By knowing each stakeholder's position, we should be able to devise a solution that leads to a win-win. And you get the image here of the Red Queen playing with an effective instrument for winning the game of croquet. But obviously, the statistics show that we're not winning yet. So all these interventions that have been put in place at the policy level, at the coding level, and at the hospital level, the data show that we still have a problem. And I just published a paper a couple weeks ago that says that pressure injuries in the United States have escalated to be a $26.8 billion issue. All right. Thinking back to Berwick and Hackbarth's paper in 2011, basing their understanding of pressure ulcer costs on 2004 data, this is more than half alone. And I think that's accurate because if the rates of pressure ulcer have gone up according to AHRQ, then we really do have a problem where everything else is essentially solved from a clinical standpoint, or significantly improved, and pressure ulcers are escalating, causing 2.5 million cases, 60,000 deaths. Did you know 60,000 people die of pressure ulcers every year? How many people do you think die of opioid crisis? Do you know?
A lot.
Yeah, but
That probably.
65 to 70,000 deaths.
And how many from motor vehicle accidents? About 50 something?
30 to 40,000.
40.
Opioid is number one now, right?
Yeah.
Right. But to put it in a context,
Yeah,
this is
no.
almost as big as the opioid crisis. Why is it not getting the same press? We're talking about elderly patients versus losing our youth, who are reducing our population average survival, age to end of life. So it did end up on the front cover of USA Today last weekend. I don't know if you caught that, or 2 weeks ago, where the VA now has skyrocketing pressure ulcer rates again, where out of the 178 major VA facilities, more than 50% have pressure ulcer rates that are double the national average.
Wow.
Yeah. And only 30 are performing better than the national average. So the VA in particular has a problem. But I think the 60,000 deaths is a driver here, where this is a hot area in terms of what's killing Americans, and we're not doing very much about it right now, or haven't been. So what are simple ways to correct some of these issues? And I alluded to this, but it's not necessarily through clinical practice, because I think when you look at what many hospitals, especially academic medical centers, learning health systems, the Kaisers and the like, they have got quality down, okay? But you haven't got coding down, and so if your pressure ulcer rates are still high, it might not be an issue of quality, but just that you're calling it a pressure ulcer when it isn't, or you're calling it a hospital-acquired pressure ulcer when it was present on admission, and between the ambulance ride and the emergency department stay for 40 hours and then getting them into a bed in the main hospital, nobody ever thought to look on their sacrum for a pressure ulcer, or they went straight into surgery in the trauma OR, and nobody ever thought to offload their sacrum. And we had a patient at University of Colorado Hospital. Come on in. We had a patient at University of Colorado Hospital who was in a car accident on a Friday night, drinking and driving. Had everything go wrong that could happen in that situation, with broken bones and a traumatic brain injury and a broken spine or fractured spine. So the ambulance crew did the right thing. They braced his neck and they put him on a board and brought him into the Level 1 Trauma Center at University of Colorado Hospital. The attending neurosurgeon on call that evening for the hospital, or whatever the situation was skiing, and the snow hit hard in Colorado, and the pass to get back down into Denver, if you know, from the mountains was blocked. So he was stuck on the other side of the mountains. They couldn't get a neurosurgeon in from anywhere else until Sunday morning. Okay, so this patient ended up being on a board for over 36 hours. When they put him into the OR, they checked the back of his head and it was completely mush. Like all the bone and skin had just deteriorated. And obviously that was going to happen because he was fighting for his life. So his body was putting all of its energy into repairing some of the other traumatic occurrences that impacted his body, and they never got to the point of the body couldn't respond to the pressure that was happening on the back of the head. And so, you know, I just use that example of coding present on admission is really important, because that's the differentiator between having a $5 million penalty from CMS or not in some circumstances, depending on your hospital. So what is the issue with coding? What are places that you can start? And if any of you are looking for research and quality improvement, this is a great and simple way to have a huge impact on a major medical center like this, where pressure injuries can easily be miscoded depending on the patient. Where, like I said, we have patients who are elderly who have skin breakdown that's not caused by pressure and friction, and so differentiating those types of patients from pressure ulcers, or differentiating some of the other types of ulcers from pressure ulcers, is really critical. And that goes right to the next point, being wrongly coded as other types of wounds being misinterpreted as caused by pressure. I think this is an important place to start, and we see from the analysis of AHRQ data that you can see significant 50, 60, 70% reductions in your rates just by coding. Staging too is important and sometimes difficult to detect in an early stage or unstageable wound, where you have an open wound and you're not sure whether it's a wound on the surface or it goes 3 feet deep, right? So getting the staging is important. Getting the present on admission status is critical. We have challenges, especially in patients with darker skin tones and patients who are hard to perform skin checks on. So putting all of this information together around staging especially combined in tandem with coding, could lead to a really useful quality improvement study. And I'll quote one of my colleagues at Hopkins, Peter Pronovost, who was a critical care intensivist there. We worked on a project where we implemented this at Johns Hopkins Hospital, and we were able to achieve a 75% reduction in our PSI 03 rate just by improving coding. The translation of information that you put into a patient's chart, which goes to billing, might mistakenly end up being coded as a PSI if you're not careful. And sometimes when you just put ulcer and don't specify what is the cause of the ulcer, it's simple things like that which really confuse billing and think, I guess we got to call it a pressure ulcer. But I think that 75% maybe is a lower limit, because this paper in Annals of Internal Medicine by Jen Meddings and colleagues at University of Michigan showed that they were able to adjust 90% of the variability in PSI 03 rates through surveillance versus coding. So when they look back at the chart and what was interpreted versus what the patient really had when checking using a surveillance approach, they were able to change their rate significantly. So this is a wide open area that it really is quality improvement at the institutional level, right? if NQAP or AHRQ came out with a guideline for how do you code pressure ulcers, it doesn't matter until you figure out what are the local or cultural problems in interpreting what's put in the chart and translate it into a code down the road. This paper by Squateri and colleagues right up in UC Irvine was an interesting one as well, where they looked at coding in terms of the percent agreement between pressure ulcers present on admission and what was found using surveillance methods of checking patients that had been transported to an emergency room. So I think that this is such a valuable paper because it shows that emergency rooms are, potentially the biggest hotspot for preventing pressure injury. We see only, from their study, only 36% agreement in what was found present on admission using surveillance methods in the emergency room versus what was coded present on admission in a time series analysis. So if again, like coding and staging, if you just go to the ER and do a quality improvement project there and focus on training people to do those skin checks, obviously it's complex because there's a lot of other things that are destabilizing the patient during their admission to the ER. But if you can get those skin checks underway, this could significantly reduce the number of pressure ulcers present on admission, or not present on admission.
Do you think on that documentation thing, the easiest thing to do would just be able to do like a sign out when the patient leaves and says, did the patient have an ulcer present on admission, yes or no?
Yeah.
On the day of discharge, did the patient acquire an ulcer, yes or no?
Mm-hmm.
And then who cares what the biller or encoder say at the end?
Yeah.
Because at the end, you say the ulcer was present or was caused by ischemia, not caused by, that just seems like it would be the easiest thing to do.
Oh, yeah.
And then you would eliminate that variability in someone who has no medical knowledge to review
Yeah, I agree. I don't think this is hard, right?
It just seems like
it just needs to be done and standardized. So if you standardize this approach of as soon as the patient who's in the ER in the bed is being admitted into a unit, that there's a protocol in place to do a thorough skin check before they go out the door of the ER. The challenge is that most of these wound teams and champions are not based anywhere close to the ER, right? They're always up in critical care and oncology and surgery. So getting a skin team down to the ER to respond to admissions cases is an important step. And so, if you champion that here, that's a huge win for the whole Keck system.
This is something very similar to what one of our team members, Joyce Peralta, did with Fred Weaver.
Okay.
In just looking at assiduously looking at a tracker.
Yeah.
For hospital length of stay.
Mm-hmm.
Ended up driving down length of stay, and we go over that. Everyone knows it's painful. We go over every Thursday the tracker, and I used to think it was the wrong. I thought it was medicine at its worst and most crass.
Yeah.
I don't think that anymore. It gives us an excuse to go over the medicine, the patient list, and to talk about methods of care. And I think it ultimately improves quality. It also saved the hospital. I understand something. You guys remember? Something was it $5 million?
Something.
It was a crazy amount of money.
Yeah.
And it became the most popular manuscript at the vascular annual meeting last year.
Nice, yeah.
Yeah,
Wow.
a little 4'7" a nurse trying to peer over the
sure.
giving her oral. It was awesome.
That's amazing.
Yeah,
Good
and so
story.
this is something very, very similar where we can really make a difference. It just sounds like people are getting. By the way, we're getting right up against time.
Okay.
Well, we should let you keep
We
going.
have until 10:30, or
Do we have till, what are we supposed to, I thought we were till, are we supposed to be till 10? I don't even know, anyway, keep going.
10?
Yeah, just keep going. Or 10, we keep going.
I can fast forward,
please
but
do.
you get the point.
I do.
And that there's a huge opportunity here.
Yeah.
I'll fast forward to the last key takeaway here, which is how do we solve this? Because you have a problem with PSI 90 and pressure injuries are in the middle of the discussion. And so I think we need to flip all this stuff upside down and rethink things using like a Donabedian framework, structure, process, outcomes, because this checklist is valuable not just to pressure injury prevention, but the prevention of most hospital-acquired conditions. When you look at the what's been accomplished, we have all these checklists now. And it's created this scenario where you need a different checklist to prevent a different hospital-acquired condition, and it creates a complex system. So for all of these PSI 90 indicators, we have a checklist for every single one. But my question is, can we create one checklist that's perhaps focused around pressure injury prevention and addresses the needs of patients with many complexities, right? Because mobility is a pressure injury prevention issue, but it's also a fall issue, it's also a DVT issue, it's also a VAP issue. And moisture and incontinence is a pressure injury issue, but it also connects with CAUTI and bacterial infection. And so if we focus on pressure injury prevention at the center of PSI 90 and create a protocol that prioritizes pressure injury prevention but manages mobility, moisture, and nutrition as well, then I think you tackle a lot of the tangential hospital-acquired conditions in a new way. I can send this slide to you as well.
Please do.
Yeah.
Just want to get a picture of you.
Yeah.
Just very attractive. That's nice. Good.
Okay.
Excellent.
Lean in, right? And so I'll close with this, which is a new paper that Joyce Black, who is a really impactful WOCM from University of Nebraska, and I worked on, which is to create a new checklist that tackles pressure injury as a priority, because obviously if we have soaring rates, we got to reverse that effect. But the benefit of this checklist is that it covers a lot of those angles of nutrition and moisture and mobility management, so that then we're having a positive effect on all of the other hospital-acquired conditions as well that are measured under PSI 90. So I think it just creates a more elegant solution of, rather than have 10 checklists for 10 conditions, have one checklist that tackles most of the parts of other conditions. And you have to think about the quality improvement to make it work in tandem well, but this is an important consideration if we want to get all PSI conditions down. So I'll close there, and happy to take questions, but respect your time, and thanks for listening.
First of all,
Okay.
but I mean, that grand unifying checklist, I think, is a great idea. 'Cause
Yeah.
I mean, like, if you could put that together, then you're a master of the universe, because you
It's the next level.
you eliminate all this timeout and checklist fatigue and
Right.
nihilism
Right.
about the thing. But I mean, but is it your perception now that people are just getting disincentivized because all they have to do is avoid the 90th percentile, and so everyone's just getting incentivized to be average,
Yeah,
and they're still crappy?
That would have been my next
Yeah.
part of the discussion if you want
Yeah.
me to just add, but we've only got a stick approach where we're
Yeah.
punishing hospitals that fall into the bottom. What if
Right.
you create a carrot that they can chase after and try to win? And so, I've proposed this equal-sided risk model, the CMMI, where we reward the hospitals that are in the highest performing quartile, and it's a zero-sum game for CMS, right? Because they take the revenue from the PSI 90 penalties and then reward it back to those highest performing hospitals. So they don't lose money, which they never like when you have a proposal that suggests that. And it gives every hospital an opportunity to strive for more revenue, which is good for these hospitals since they lost it on the non-payment. And when you think about what you can use that money for, Peter Pronovost and I wrote an article just discussing the fact that hospitals need financial support to increase the bandwidth of their quality improvement. And so this reward is something that if hospitals invest independently in improving quality today, in the future they get the reward, which is their money back for investing in a good quality system.
Do any of these things go toward improved or like ranking in some of the non-governmental ranking lists? These lists that are always advertised from hospital to hospital.
Yeah, the U.S. News and World Report.
Yeah.
These quality indicators are in all of those ranking systems. The one where it has the biggest effect is on the magnet, nursing magnet, which hospitals invest hundreds of thousands of dollars, and that has the other ones too. And so, in magnet, pressure ulcer prevention is an explicit measure. In U.S. News and Beck's and all those, or Beckers or whatever it is, they're implicit, but they're part of a bigger scale or index of quality. Yeah. So you're winning multiple ways with this.
Any other questions? Listen, man, thank you very much.